We're going to have a look at the non-invasive ventilation machines that we use here. This is a sleep cube. So this is for people who aren't acutely unwell and on low levels of oxygen, because we need to entrain oxygen into this device. We wouldn't use this machine with anyone who needs more than 8 litres of oxygen entrained. The same for the focus ventilator. It doesn't have a high pressure oxygen inlet, so we can only entrain oxygen into the patient's mask or into the patient's circuit. So again, whilst it delivers BiPAP and CPAP, we can only use it for patients who have low oxygen requirements. If we move to my left, these 3 machines all have high pressure oxygen inlets, so they will all deliver 100% oxygen if we need to, so they go from room air to 100% oxygen. This is a Trilogy 202. This will deliver CPAP and BiPAP, non-invasive CPAP and BiPAP. It is actually designed as a home, non-invasive and invasive machine, so it has lots of different modes on it, but we're just going to talk about non-invasive ventilation, non-invasive CPAP and BiPAP today. The same with the Evo. The Evo is the new version. Trilogy Evo is the new version of the Trilogy 202, so that delivers the same, again, home ventilation, non-invasive ventilation as well as invasive ventilation. And then moving on to the V60. So this chap delivers BiPAP, CPAP as well as nasal high flow oxygen, and is our most utilised machine. These videos are designed to help you when you're setting up BiPAP and CPAP and deciding whether you need to use BiPAP or CPAP, regardless of your ventilator. So we use CPAP for type 1 respiratory failure, so for patients who are hypoxic but not hypercapnic and a pH normal. We use BiPAP or bi-level positive airway pressure for patients who have respiratory acidosis and are hypercapnic and their pH is low. Before we use BiPAP or CPAP on anybody, there's a variety of things that you need to do from a safety perspective. The BTS and ICS guidelines have an exhaustive list of all the things that you should do, but we start with a chest x-ray before we use any form of positive pressure ventilation, non-invasive ventilation, to make sure that the patient doesn't have a pneumothorax. If a patient has a pH of less than 7.25 and they're acutely unwell and extremely acidotic, then it's okay, as long as a senior doctor has decided that patient's unlikely to have a pneumothorax, to set up a BiPAP or a CPAP whilst you're waiting for the chest x-ray to be done. The other thing that we need to do is make sure the patient's not vomiting. You don't want someone vomiting into a non-invasive ventilation mask, it never goes well. You need to make sure that the patient hasn't got any facial injuries. You can't use non-invasive masks with patients with facial injuries. The other thing you need to be thinking about is their blood pressure. If you put positive pressure into somebody's thorax, then sometimes it can reduce your systolic blood pressure. So we like to see a relatively healthy blood pressure before we put BiPAP or CPAP on somebody. Of course, that's manageable with fluids, so we need to be making sure that we've done a blood pressure before we put NIV on. We, as a rule of thumb, like to see a systolic blood pressure of 100, but we can be guided by our medical colleagues. Another precaution to take in mind is your GCS. So obviously we need to make sure that the patient can maintain their own airway and they have sufficient respiratory effort to use non-invasive ventilation, especially with CPAP, because CPAP is a spontaneous mode and the patient has to be taking every breath themselves. Bi-level non-invasive ventilation does have a backup rate, so the machine will give the patients backup breaths should they not be taking them themselves. While a patient is on non-invasive ventilation, we need to monitor them extremely carefully. We have a 24-hour ECG attached to the patient. We monitor their SpO2 continuously and maintain their SATs within target range, and we keep a close eye on their blood pressure. After the patient has been on BiPAP or CPAP for an hour, we repeat a blood gas and make sure that their oxygenation in type 1 respiratory failure is much better, or where we want it to be, and that pH and CO2 are starting to correct in patients with type 2 respiratory failure. If that's not the case, then we need to amend the pressures that we're using, or mask fit, or a variety of other things that could be affecting why the BiPAP isn't being effective. I just wanted to introduce the types of circuits that we use in Bradford Royal Infirmary for our BiPAP and CPAP machines. We have a dry circuit here, which is quick and easy to set up. It's essentially wide bore tubing with a filter either end with a pressure line. We only need the pressure line for some of our ventilators. For other ventilators, we remove the pressure line, but please see the videos on the different ventilators that we use here. The wet circuit we use for patients who require CPAP or nasal high flow. If you need to set up CPAP in a hurry, then we would set them up with a dry circuit. But if they're on CPAP for any length of time, then we would need to introduce a wet circuit. We use a wet circuit, which is essentially a very well humidified circuit because high flows of oxygen and dry gas are damaging to the airways, and we get all sorts of problems like sputum impaction. Also, patients won't tolerate it. It's very uncomfortable if you don't humidify the circuit. So we must always use this for nasal high flow. In CPAP, as I say, if patients are going to be on CPAP for any length of time, then we would put a wet circuit. Here we've got a sleep cube, which we used during the COVID-19 crisis, and we are still using them. Essentially, it's a fixed CPAP that comes with its own circuit. We have an oxygen entrainment port at the bottom, again, non-collapsible tubing. We have a filter at the patient end, and we fit the mask onto there. The oxygen tubing goes onto the flow meter on the wall. We like, because these circuits are filtered at the patient end, so inhaled and exhaled gas is filtered, we can reuse this circuit. So once this circuit has been used, it needs to be retained, and we clean it and we use it again for the next patient. An introduction into some of the masks that we commonly use. You can see we've got different styles of mask here. Each mask comes with its own measuring device. So these masks here come with a measuring device like this, which essentially guides you whether your patient needs a small, medium, large or extra large mask. It's very important to get the right size mask, otherwise people get very sore faces, and that really affects compliance. Other types of masks have triangles cut out of the bag that they come in, and again you would put that near the patient's face to decide whether you need a small, medium or large mask. I would encourage everyone to do that before they fit a mask. Before you put a mask on somebody, you need to make sure that you have a filter in place. This is the exhalation port on the tubing that we use, but between the exhalation port and the mask you need a filter. We've got two different types of filter here. This is an antibacterial and viral filter. This is an HME, a heat and moisture exchange of filter. The HMEs essentially catch heat and moisture from exhaled breath and then use that heat and moisture to humidify the next breath in. So they can really help patients not feel so dry, and again improves compliance. They must be changed. Both sets of filters need to be changed every 24 hours. This filter may need changing more often because sometimes they get wet. These are examples of the high flow nasal cannulae that we use. We use the Philips Respironics with the V60s if we've got them, although you can use these two interchangeably. This is an Optiflow nasal cannula, but as I say, you can use either on both machines. They both work equally well. You can't use a normal nasal cannula with nasal high flow. It has to be a specialist nasal cannula.